Welcome back, everyone. It's my distinct privilege and pleasure to welcome our keynote speaker, Maria Hernandez, who is President and COO of Impact for Health. She is going to share with us some thoughts and perspectives on health equity, data, processes, and strategy, the new disruption in healthcare. I am so excited to have Maria here. Welcome, Maria.
Thank you so much, Mark. It's a pleasure to be with you and everyone today. I will be speaking about how the current focus on health equity is disrupting healthcare for the best. It is changing the data to be collected on patients. It's changing the type of care provided, and it's changing our strategy or approach for delivering care. So before I get started, I want to thank so much Healthcare Innovations for this opportunity, and I want to thank you all for listening to this presentation. I wish we could be in person, but I hope the next conference will give us an opportunity to get together in Los Angeles, my hometown. So as Mark said, I'm President and COO of Impact for Health. We're based in Oakland, California, and we're a subsidiary of a firm called Inclusion Inc., which was founded in 2001 with clients in the Fortune 100. Impact for Health was established in 2015 with a real specific intention of bringing innovations that we had seen in diversity, equity, and inclusion in the corporate sector to healthcare. So prior to this, I was primarily consulting in consumer products and technology. And shortly after the firm was established, I also became a trustee at Alameda Health System, an essential hospital serving the East Bay in the San Francisco Bay Area. It's actually my dad's first battle with cancer, though, that created the momentum for my desire to dedicate my work to disrupting and changing healthcare. I want to share a moment with you that really, truly shaped my career these past 10 years. My dad, a non-smoker, was diagnosed with lung cancer, and the day of his surgery to remove part of his lung, my mom and two older brothers were wishing him well, and we were speaking Spanish because that's our norm as immigrants. And we were pretty surprised when he suddenly raised his hand and said, "Stop, don't speak Spanish. They're going to think I'm stupid, and they're not going to take care of me." I was really stunned at his remarks, and it prompted me to dig deeper into bias in medicine. And I started to uncover the sad realities about what happens to people who speak a language other than English. I realized that what I was witnessing at that moment was the potential for the beginnings of a health inequity, except he had me and my two older brothers, and one of my brothers is a physician, to be his advocate. So I dedicate this work to him and all those who fear for their lives just because they're different in some way. So in order to understand why the demands of health equity are such a disruptive force in healthcare today, it's key to first understand the many dimensions of the crisis our nation has experienced these last couple of years. There are really three factors making it impossible to ignore the need to advance health equity. Of course, the pandemic alone would have been enough because it was clear that the people dying from COVID-19 were the frontline workers who are largely Black, brown, and often the working poor. But it was the murder of George Floyd on the national scene that was the last straw for many people of color, including those who work in healthcare. The rallies in the streets, the activism by Black Lives Matter were matched with events and vigils inside healthcare systems. Many were overwhelmed that it was their neighbors, their friends, their family who were coming to the hospital and dying. And so this is what next happened. The mainstream media began to confirm what demographers have studied for a long time, and that's the US is becoming more diverse. For the first time in the US, more people of color were born than whites, and the browning of America, as some have said, had so many in population health, realizing that healthcare systems need to meet the needs of very different people in the future. So what does it mean to achieve health equity? Let's talk about what the CDC says. Health equity is achieved when everyone has the opportunity to attain their full health potential. It requires addressing social, structural, and political determinants of health, like poverty, like safe housing, or food insecurity, or access to healthcare, or systemic bias. In medicine, we may think that treating everyone the same is the ideal. It speaks to our core values as a country in fairness, but unfortunately, treating everybody the same only works if we all start from the same place or have the same resources. And we know that's just not the case. This graphic, and there's a whole bunch of different versions of this, it's a symbolic representation of a reality that equal treatment doesn't necessarily produce equal outcomes. Equity is a focus on how we distribute resources in the system, and equality is how we focus on distributing those resources in the system. Equity is a focus on the outcomes of that system. And every health system strives to provide the highest quality of care, but health inequities speak to how much more there really is to do. So we've actually known about health inequities for over 120 years. The University of Pennsylvania has an extraordinary online collection of all the studies, all the reports, all those white papers that have been published on health inequities. And well before the pandemic, we knew of inequities in maternal health, infant mortality, heart disease, and diabetes. And each of these has links to race, ethnicity, and socioeconomic class. More recently, it's also become clear that your zip code is a greater determinant of your overall well-being than your genetic code. This speaks to the many different factors that shape your life simply because of the street you live on, your access to good food, clean air, safe streets, or good schools. And you might have heard this expression before, that place matters, and it does, in years of life and quality of life. So to understand the health and well-being of an individual, healthcare systems have to recognize that there are conditions in which people live and work, and those play a really significant role in the care and treatment of a patient. So despite our knowledge of health inequities for over 100 years, it's the last 2 years that have brought into clear focus that health systems are facing increasing pressure to mobilize and address this sad reality. And that pressure is coming from community groups, patient advocates, elected leaders, and from within medicine itself. So it's forcing enormous disruption while the nation continues to become more polarized about race, social, and economic justice. If you do a Google search on the term health equity between 2018 and today, you'll get about 98 million records. If you do the same for the time period of 1990 to 2018, a time span of 28 years, you get a return of 92 million records, almost the same amount, but so different in the last 3 years. As we have talked so much in our country about the need for health equity, we're writing and speaking about it so much. According to LinkedIn, the most sought out position in the United States today is the Chief Diversity Officer. And I think what's next after that is like computer analyst. So that should tell you how important this is now. The American Medical Association published its first ever organizational plan to embed racial justice and advance health equity. And the American Hospital Association has released a really comprehensive health equity toolkit for health systems to use. As I said at the start, the focus on achieving health equity is truly disrupting healthcare in 3 key ways, and I want to talk about each of these. It's the data that we collect on patients, it's the type of services that we're providing, and it's our strategy and the culture inside health systems that are really being forced to change. So I want to walk through each of those. And I also want to share with you what Impact for Health is doing to play a role in helping facilitate that kind of change within health systems today. So I think it's important to know that the disruption in healthcare starts with the type of data that we are now collecting in order to provide quality care for all. So health systems are starting now to gather information about the communities where they serve patients. They're looking at the determinants of health that individuals might face. They're expanding on the data about patient characteristics. And we're much more better or improving our approach to looking at what happens to the patient as a result of the care they receive. We're really looking at the health outcomes. While we've been looking at patient outcomes for a long time, we haven't focused on the factors you see here in the first 3 columns enough. And that's really changing right now. So the good news is that now there's an ICD-10 code for social determinants of health. And of course, you know, once healthcare has a code for whatever ails you, that's half the battle, right? Z codes are being integrated into some electronic health records. And this means that health systems are asking patients about what they feel safe, whether they feel safe in their home, if they have enough to eat, or if they have income to support their basic needs. And these factors can now be used to refer those patients to an additional set of resources or different programs in the community that provide different types of care management, something that's more meaningful to meet their needs and help them actually stick with a healthcare plan or a disease management plan. So those new services and models of care are disrupting service delivery strategies. Telemedicine is the tip of the iceberg. It's just one example of this. We also know that care provided closer to home is key, and that coordinating a lot of different services, a lot of different approaches to managing a chronic disease in one setting, it improves the likelihood that patients stay engaged in their treatment plan. It's also becoming increasingly important to recognize that early childhood trauma, like extreme poverty, abuse, or neglect, they all have very long-term physical and emotional consequences that impact the quality of life. And a running theme through all of what I've said so far is that culturally effective care is really fundamental to long-term success with some of the most at-risk patients. So the last disruption is, I think, one that I will refer to as the internal strategy, the internal culture at most health systems. So Impact for Health is currently working in about 6 different healthcare systems across the country. And my experience is that many of them are looking how to bring together the leaders that manage very different responsibilities. They have very different roles and they're in very different silos. It's HR, it's diversity, equity, and inclusion, it's quality or patient experience, and community engagement. Those are the departments most often needed to come together to align on new ways of working together. And that's no small thing. So any discussion about innovation is never complete unless we glance at what's happening in venture capital, the disruptors who seek out opportunities in every crisis. The global investment in healthcare startups set a new record in 2020, reaching $80 billion in equity funding. And Forbes just recently reported that 2021 saw twice the number of deals in the US for digital health in the first half of this year than all of the deals in 2020. So I know a couple of startups that are starting to look at what do we do differently to serve the Latino population, which is soon going to be 20% of the population. That is going to disrupt a lot of the things that we do, right? And so the drive for health equity and the increased scrutiny that many healthcare systems have experienced over the disproportionate number of deaths of Latinos and African Americans is really deeply felt and painful. And it's obvious that we're really ill prepared for the pandemic. We were even less prepared for how to reach those communities of color that suffered the most deaths from COVID-19. And so I think, again, I would argue that the drive for health equity is going to change healthcare in profound ways because it's already started. And I want to conclude here with a little bit of that background on what Impact for Health is doing to partner with some of the largest health systems in the nation and also some of those regional standalone sites. 3 years ago, we started to think about how could we operationalize health equity. We wanted to capture the key insights, the key recommendations that were posted in so many different articles about how to reduce health inequities. All of the major organizations serving healthcare wrote about this: the CDC, the Institute for Healthcare Improvement, the American Hospital Association, the American Medical Association. We also wanted to understand what some health systems were already doing to serve very key populations. So the Inclusion Scorecard for Health is a summary of about 75 different practices based on all that literature that we reviewed and some key interviews with leaders in different healthcare systems. We've placed this online for health systems to use for free. And for each practice we identified, we created an integrated knowledge base to provide more context on why that practice is linked to reducing health inequities. So if you look at the 4 sections here, there are several different practices organized under the 4 banners that you see. So the first one is the metrics of inclusion for healthcare. And here we've listed the data needed on patient demographics, community conditions, and staff to support health equity. So for example, we asked, does this hospital review health outcomes by race, ethnicity, language preference, or sexual orientation and gender identity? It's the real and SOGI criteria that you're going to start seeing in more and more systems as they collect data about patients. Another is the hospital collecting information on a community's social determinants of health? Does the hospital look at patient utilization data by those demographic groups or by zip code? Those are examples of the items that we have in that first quadrant. The second area is about all the practices related to creating a culture of inclusion inside healthcare so that diverse patients feel safe and welcomed. It's also about looking at those practices that support the staff. For example, are there culturally effective services for patients tailored to their specific needs? Or does the site provide training to reduce the impact of unconscious bias? These are the activities, quite frankly, that we saw in corporate settings way long ago compared to what we're now seeing in healthcare. And so some of these are very typical of those efforts to make sure everyone feels safe, everyone feels like they belong. The third section of the scorecard is probably the hardest one, and that's because this looks at whether or not the system is linking quality of care with health equity. Who is responsible for tracking those health inequities? Are leaders expected to demonstrate cross-cultural effectiveness? These are practices that require real commitment to health equity. It's how you walk the talk, right? And the last section is dedicated to how the healthcare system is engaged in the communities they serve. So is there a community advisory council on health equity? Does the system work with local nonprofits or faith-based organizations to address those social determinants of health? And now it's even more important that there are investments in those local initiatives to provide health advocates, patient navigators, sometimes called promotoras in my community, to meet patients where they live and work and help them navigate to the services that they most need. So the use of the scorecard is currently on a technology that health systems already use. Sometimes it's used for strategic planning or project management. And we did this on purpose to try and reduce any kind of barrier to adoption. Hospitals are very particular about what they can use and what systems are allowed within their firewall. So this became a very important decision for us. And what you're seeing on the screen right now is a screenshot of the scorecard items in one quadrant. It sits on a Smartsheet. Smartsheet is a commercially available product. And the pop-up window of information that you see here about a specific practice is actually based on Evernote. And we update the background information on a regular basis without having to disturb anybody using the platform. So you click one day and there's 10 items for you to review in terms of resources, and maybe next week there might be 12 or more. So this is just a static shot of the way in which Smartsheet displays the different items that we have placed inside the scorecard. So implementing the scorecard has 3 steps. The first is to assess the current use of the practice in the system. And we've got 3 criteria for the evaluation. So first, is there any indication that the practice is reflected in an existing program, an existing initiative, or is there even a goal focused on creating efforts to support this practice? And then the next criteria is, are there adequate resources assigned to this practice? So as we all know, you can say you want to do something, but if there's no budget, no staff, or other resources, it's really not going to be implemented. And it's not really a serious commitment by the organization. The last criteria is whether or not that practice is actually discussed as part of the system's overall health equity strategy. The scoring on this is on a scale of 1 to 4, and here you see a rating scale to determine if a practice is a strength, an opportunity, or if it's at risk and needs more attention. The next step is for us to define the from-to gap. So where's the organization today in this practice, and what would be the target future state? We teach different individuals within the organization how to do this assessment. And a lot of times we're invited to conduct this work initially to just sort of role model what that looks like. And we really do want to see that internal capacity grow so that the organization can actually continue to do this for themselves. No one does all 75 practices at once. And so we try to train for this, and we'll often have an existing internal staff member join us on our interviews. So normally we'll interview 2 to 3 individuals who might be responsible for the practice or play a role in the work streams involved around this particular activity. And we do that to get a description of the current state and to determine what the ideal future state may be. And then we create a set of milestones necessary to achieve that. And so all of this information gets uploaded into the platform so that even after we're done, others can continue to update that or come in and modify it or continue to do additional assessments that are based on new developments for that particular practice. So the last step is to support the development of a health equity dashboard. And this is a set of key health outcomes that the system is going to track to see if indeed there's improvement in the patient experience, in the patient outcomes. So for example, did we actually reduce rehospitalization rates? Did we improve the use of the ED for key conditions that might be better served in a community clinic? Do we have better HCAP scores, the satisfaction that patients have around their stay at a hospital? Or did we improve the rates of cancer screenings? All of these are no longer going to be looked at as one number, an aggregate. They're all going to need to be looked at by real and SOCI, those demographic groups that I mentioned a moment ago: race, ethnicity, and language preference, and sexual orientation and gender identity. It's amazing, but that wasn't done just a short time ago, even at the hospital where I was a trustee. And part of it was because of the electronic health record and how we needed to modify that in order to be able to collect and assess that information. So it's happening. This is all changing at once. So one of the most interesting and rewarding elements of bringing the scorecard to the health system is that it's forced to break down in silos. And leaders start to look at different divisions and the interdependency between all of the things that are required to retain a diverse staff and serving diverse patients. And they really do see a clear link between investing in community initiatives and meeting the needs of the patients that struggle with food insecurity or poor housing. They see the value of looking at those quality metrics for the unique populations that they serve and recognizing if we want to achieve health equity, we may need to indeed shift the resources and change strategies. Healthcare is not a one-size-fits-all environment. It never has been, and it never will be. So we need to behave accordingly. I want to thank Healthcare Innovation Group for inviting me to this summit, and thanks for watching this presentation. Please reach out to me if you have any questions. You can find my number or my information at our website, www.impactforhealth.com. And also, please visit our podcast, which is calling Centering Health Equity. It's available on Apple Podcasts and Spotify. Thank you so much.
Maria, thank you so very much. This was so great. I absolutely loved your presentation. So first of all, thank you.
It's my pleasure.
Now, let me ask you a few questions. Well, first of all, one thing I'd like to say, you brought receipts, as they say. A lot of times when people are talking about equity in society, they get very stuck in almost the first initial discussion. What is equity? Do we have it? Maybe we don't. And people get caught up in really, really basic conversations.
Mm-hmm.
One of the things that I think is really interesting about how you and your colleagues developed a scorecard is you have measurements all along, right? You say, well, this is what this means. Here's how you move toward that. What advice would you give to people who would like to really move forward on this journey, but their organization probably is extremely early in the journey, extremely early. And in some cases, they have to convince their C-suite members and board just to go ahead and start this, right? And there can be so much, I'll use the word fragility, right, around this. Oh my gosh, people will think we're bad people, all of these things that happen, right? What would your advice be for someone who perhaps has seen this presentation today and says, my gosh, Maria is exactly right, we need to do this. And then 1 second later, they're gripped with fear. Like, how do I even explain this to the C-suite and the board? How do I get them to buy into this concept? How do you get over the initial resistance to this?
That's a common question that we get asked. And my answer is, if you're dedicated to health quality of service, you have to look at whether or not you have health equity.
Yeah.
So if you are looking at your data and you're really comfortable because that aggregate number looks really good, you might be surprised what's underneath if you peel that first layer of the onion and start looking at, gee, do we have that same kind of results with diverse populations? And your diverse populations may be unique. It could be elders, it could be LGBTQ, it could be any number of unique diversity that you're working with in your community. So I know that most systems pride themselves in giving the best quality of care. And if that's your mantra, wouldn't you want to know that that's actually happening for everyone?
Yeah.
Right?
I think that's wonderful, Maria, because you can really, it's hard to resist quality, right? Like no one, and also I think another word is mission, right?
Sure.
I'm certain when you go in and you speak to people in healthcare organizations, they all say that their mission, if you go to any website of any hospital system, their mission involves a healthy community and all of those things that is baseball mom and apple pie, right?
Right.
So I think if you bring in mission, that probably will help a lot.
It does. I think that you'd be surprised how many hospitals do not have the word diversity, equity, or inclusion in their mission statement. And we call out after we've, sort of earned their trust.
Yeah.
That's probably a pretty significant liability on their part, because more people are now aware of the inequities that exist, and they're asking for accountability. And so whether it's happening from inside or it's happening from the outside, people are beginning to ask, do we really do a good job with everyone? Or are we best only with a certain demographic group? And if so, we need to change that. This is the time to move forward. Yeah.
Absolutely. What I'd love to have you do, and I know you can't name names, you could just say health system A or something like that, but maybe a couple of very brief examples of health systems that have really taken the plunge and done well. What have they done? Just a couple of examples of things they've done right.
So the first thing that they've done is that they've been honest about the failure. They've been honest about not meeting the needs of everyone. And they've done internally the hard, heavy lift of showing what a medical error is and how it happened because of a lack of understanding of a person's culture, a misunderstanding of language. And so they have internally featured those examples and then talked about the impact of unconscious bias in medicine. And they have said openly and candidly, we all have unconscious bias. It's part of human nature, but we in medicine have an extraordinary responsibility to do what's right and to make every effort to train ourselves not to let that happen. And so I've participated in some of those trainings, and I think that physicians pride themselves, of course, in obviously wanting to do the best for all. But once you present the data, it becomes very difficult for physicians to say, oh, that doesn't happen, or no, that must have been a fluke, right? And I've heard that actually in trainings. Oh, well, that was just one thing. Wait a minute. How do you explain that Black women die at 2.5 times the rate of others in childbirth in this country? It almost approaches third world nation status, right? And so you can't turn your eyes away from that and say, oh, that's an accident, or that was just somebody not doing the right thing. No, there's a pattern, and that pattern needs to be addressed. So that's what I think they do the best. I think the ones that don't do well are the ones who try to deny it, who try to rationalize or sweep it under the rug. Heads roll because, maybe it's easier to say it was that person's responsibility to oversee that. And this is a systemic factor. This is not just one person. Yeah.
And one of the many, many wonderful things about your program is that it moves it to systemic discussion, right? I have seen in organizations across numerous industries, they'll hire a diversity director or whatever they call it. And so then Susie, everything falls on Susie, right? Like this one person is going to transform the organization.
Right.
And we know that that doesn't work. And in fact, it's almost a recipe for defeat, right? Like, we're just going to hire Susie. We're not going to give her any resources. We're not going to make it clear that the CEO, the C-suite, and the board support her. It'll just be Susie will figure it out. And one of the most important things that I think you articulated so beautifully just now, this is systemic. It requires a village. It's not just, it's never going to be one person or two people or three people.
Right.
I also think that one thing, I'll make an observation, one thing that is helping the cause now is there have been so many great articles in Health Affairs, the New England Journal of Medicine, things sponsored by Commonwealth Fund, that have shown persistent bias in so many areas. For example, there have now been numerous studies that show that Black Americans in particular face tremendous unconscious bias around simple things like pain medication administration. There is, and it's at such a deep level of thinking that people are not aware of it, that they're assuming that Black men and women have higher pain tolerance, right? And so they're in their minds unconsciously or subconsciously adjusting for that. That's one example. Another area that I think is helping the cause is more and more people of color are coming into leadership now in health systems. So now it's not it's not just Susie, but there will be actual members of the C-suite who will say, well, my lived experience as a person of color is actually that, blah, blah, blah. And they will have the cultural competence, correct?
Absolutely. And I think that is one of the reasons why, if you want to provide the best quality of care for the diverse populations of the communities you serve, your organizational structure, the staff, the middle management, the executives, they all need to reflect that community. And that means extra effort and hard work to go recruit and retain those individuals. You don't want a revolving door. But I think I want to stress one thing very much so, as you said, this isn't a one person job. It's
Right.
everybody's got to have it on their performance objectives, that they have a direct line of responsibility for health equity, diversity, inclusion, and that sense of belonging. And you're starting to see something that we saw in the corporate sector quite a while ago, now coming into healthcare, which is any kind of performance bonus or performance appraisal is now tied directly to some of those metrics that are in our scorecard. Are people feeling engaged? Are people feeling like, this is a great place to work? Do they find themselves, more likely to want to stay than to leave? So all of that is really important as this transition occurs.
Wonderful, thank you. What do the next few years look like to you in the healthcare industry?
Well, I think there's going to be more disruption by some of those healthcare startups. Some are looking at, really different ways of approaching data gathering and combining the data from communities and from the individuals to look at what is the best course of care. There's some pretty fascinating things out there. But I do feel healthcare is in this transition. We are not in the business of keeping people well. We are in the business of taking care of people who get sick. We need to transition into a well-being industry, and that's going to look really different. I had a colleague, David Katz, at an event say, we're almost like where the energy sector was. They know they can't just be drilling for oil. They got to come up with solar energy and wind power and all of these really cool renewable energies. What would that do in medicine? What would that look like for us, right? And so imagine that, there still will be hospitals for people who are ill. But what if medicine gets into the type of food you eat? Medicine gets into the type of retreats that you go to for, wellness breaks and what have you. There's a lot of opportunity for us to shift gears. So it's going to take a while. But on the short-term front, I think we're going to see a lot more effort to bring together that C-suite to look at those health outcomes and get better and better at that data, so we understand what's really happening to the communities that we serve.
Absolutely. And I think one of the things you mentioned earlier on, and I'm so glad you did, you referenced promotoras. Mm-hmm. And I think one of the things that is exciting is that we're going to see activity from the bottom up and the top down at the same time, right? Sandwiching. That's how we get this done in so many cases. And I think what promotoras do is so incredibly important. And it's being done in many, many communities now, not just Latinx communities, but in, Vietnamese, other groups as well. And one of the things that's so great there is you're actually now connecting to the community. Mm-hmm. And I think that will be obviously a key ingredient. And you had referenced that as well.
Yeah, well, imagine it's much better if you can get the care you need within a few blocks of where you live. Or you can go see people where you live and work, who are like you, who can support you and understand what your lived experience is. And, too many healthcare systems are so complex. When you walk in the door, even if you speak English and you know how the system works, we look around, where do I go for my lab work? Or, it's really complicated, right? And so I think you're right. We are going to see more disruption about how people get care, how people do what they do.
And the initial discussion, if there's a member of your community who speaks your language and who understands you culturally, speaks your culture, not only your language. So often I think it gets reduced to language, and that's only one piece, it's culture. That's the person who can help you with your lifestyle. You know, as we know, for example, diabetes is so big, unfortunately, in Latinx communities. And so promotores and other people who understand the culture can really engage with individuals. That's where our health system has to go anyway, right?
Right. And there's a great example of that in Los Angeles. White Memorial in Glendale has made a
Yeah.
very concerted effort to actually address that population. And, you know, traditionally when we have someone that's, you know, presenting with diabetes, you might say, you know, you need to cut this kind of food down, you need to exercise more, maybe join a gym, what have you, right? But that doesn't necessarily work in the Latino community. Those decisions about your diet and, you know, your exercise and your routine, it's a family decision.
Yeah,
And
exactly.
so they took into account that maybe we don't talk about the same sort of approach for that community. We look at, maybe we talk about how to make those tacos and burritos a lot more healthy, but don't change
Exactly
the
it.
diet in
Right.
a, you know, really big way. And we talk about the things you can do with your family, you know, go play, you know, a game of soccer with your kids or do
Right.
something that's outdoors with them. And that's what culturally competent care looks like. When
Exactly.
you
Exactly.
take a moment to really understand the community that you're trying to serve, and you ask yourself, you know, they're going to see this in a certain way. Let's
Yeah.
talk to the individuals involved, ask them what they think about these different approaches, get the community groups that are really engaged with that population and ask them what works, because you know there's a lot of really smart people inside those communities and they
Right.
can support the hospital in doing that. And as I say, I don't think this is something we can solve inside the four walls of a health
No,
system. It's going
absolutely.
to take all of those different community partners to really make a difference.
Exactly. And when you break it down, for example, I love your example about the tacos and burritos, because let's say you're meeting with someone who's 25 years old and they're still living at home. You need to make sure that their mom hears this, right? Because she's the one who's going to be cooking the dinner, right?
Well, she's the boss anyway, right?
Yes, that's right. So unless you can somehow reach her,
Yeah.
just telling a young adult you need to eat more fruits and vegetables isn't going to do it, right?
Right. Right.
So I think you nailed it on the head, and I think that one of the wonderful things is that this health equity discussion is emerging full force at a time when we are, as a healthcare system, starting to look at the totality of health. So
Right.
it fits beautifully, because the mission, as you said, sadly, some health systems don't have health equity in their mission statements yet, but many do. And the mission of a community that is healthier holds many implications. It's so much beyond, we'll just fix you when you get super sick,
Yeah.
right? So
Well, the healthy community is a community that's economically vibrant. It's a community that can be resourceful and do
yeah,
so much more than a community that's suffering from, you know, chronic disease. I just would say again, we have to know what data to look at to track this. We have to know that it's going to require a lot of change in what we do, how we provide the services. And that change is, you know, going to have to come from within those systems first and foremost in many ways, so that leaders get the big picture that needs to be addressed. And you know, again, it's so tragic that it took the pandemic and a couple of other things that are happening right now in our country to move this forward. But let's make the best out of a really difficult situation is my motto,
absolutely.
right? Yeah.
Yeah, and I think we've learned some things that will help us
Yeah.
because of the pandemic.
Right.
Maria, thank you so much. This has been absolutely fabulous. I just want to wish you all the very, very best as you continue to promote this amazing strategy and philosophy.
Thank you so much, Mark.
Absolutely. Thank you again. This concludes this session. Thank you to you and our audience for your attention to this session. Thank you very much and have a great day, everyone.